Good morning, actually good afternoon, everyone. It is my great pleasure to be here today. And I would like to thank India for inviting me to talk today about immigrant mental health, which is the topic which is quite close to my heart. I'm an immigrant myself, and for the past 20 years, my main focus of interest has been mental health and substance use and immigrants, refugees, ethnocultural, racialized groups, and barriers in access to services. So I'm going to start with a question. Why do we need to focus on immigrant mental health? Why is it important to talk about this topic?
Because it costs our system so much money.
Yes?
There aren't enough mental health resources for newcomers.
That's correct. So, mental health is a key to immigrant well-being, successful integration, productivity. We know that Canada will continue to rely on immigrants for population growth and economic prosperity. We also know that immigrants who come to Canada, upon arrival, report better mental health than the Canadian-born population. We also know that after being in Canada for several years, their mental health deteriorates. At the same time, mental disorders are the leading cause of disability in Canada. So I think this is several important reasons why we need to talk about immigrant mental health. I just want to acknowledge my colleagues who have been involved in this work with me, Dr. Kwame McKenzie, Andrew Tuck, and Michael Antwi. And these are the topics that I'm going to try to cover or summarize in 15 minutes. And I really hope that you like data, because I'm going to continue showing some data, some graphs and charts, mostly comparing immigrants to Canadian-born population. So, as you already heard, Canada has the highest proportion of foreign-born population among G8 countries. Almost about 1 in 5 Canadians is foreign-born. Outside of G8 countries, only Australia has a higher proportion of foreign-born population. Ontario, about 30% of Ontario population is born outside of Canada. Toronto, half of Toronto population born outside Canada, and I believe in Ottawa is about 20%. The countries of origin of immigrants have changed significantly in the past few decades. Up until late 60s, early 70s, majority of immigrants, almost 80%, arrived from European countries. That has changed, and in the past 2 decades, majority of immigrants, almost 80%, arrived from regions other than Europe. Actually, between 2006 and 2011, only less than 14% of immigrants arrived from the European countries. So what do we know about immigrant health? We know that upon arrival, the self-reported health status of immigrants is better than that of the Canadian-born population. This health immigrant effect is not actually a surprise, because we are aware of the health screening and the health standards that immigrants have to meet in order to be admitted to Canada. This health immigrant effect does not apply to refugees, who are more likely to come with the different health problems because of their pre-migration experiences. We also know that this health immigrant effect diminishes with time in Canada, and you can see that the gap is narrowing after about 4 years, immigrant being about 4 years in Canada. The similar findings found for mental health of immigrants. Again, immigrants appear to have a lower prevalence of self-reported poor health upon arrival, but again, as they spend more time in the Canadian society, this healthy immigrant effect declines over time, with long-term immigrants being less healthy or reporting poor health, more likely to report poor health than short-term immigrants. So what do we know about the rates of mental disorders among immigrants? There's actually no clear pattern. Those rates vary in different immigrant groups and for different disorders. So differences according to immigration, refugee status, country of origin, age at arrival, length of residence in Canada, and visible minority status. So we know that in general, immigrants show slightly lower rates of common mental disorders, which is depression and anxiety, and in particular, recent immigrants. But again, over time, the immigrant mental health deteriorates, and the rates of common mental disorders become similar to that of the general population. What is interesting is the findings from the recent study that was published a couple of months ago that looked into psychotic disorders among immigrants. And the study found that some immigrant groups have higher rates of psychotic disorders. The study found higher rates of schizophrenia among immigrants from the Caribbean countries, Bermuda, refugees from East Africa, and South Asia. And again, this is consistent with findings from the literature and the findings from other countries. At the same time, the study found lower rates of psychotic disorders among immigrants from Northern and Southern Europe and from East Asia. Again, these findings cannot be, or differential rates cannot be simply explained by different rates of these disorders in their countries of origin. So there is obviously something happening after immigrants arrive to Canada that increases their risk of developing mental health problems and disorders. Refugees, as I said, on the other hand, have a higher rates of mental health problems and actually more risk of developing common mental disorders, psychotic disorders, and post-traumatic stress disorder. And again, we recently looked into substance use among immigrants. Not surprising, immigrants report lower rates of alcohol use than the Canadian-born population, but there are significant differences across ethnic groups. But it also, what study previously found is that the rates of alcohol use among immigrants changes with the length of time in Canada, and the previous studies found that this alcohol use among immigrants generally increases with years in Canada. What we found is actually depends on their country of origins and the original pattern of drinking. So for some immigrant group, this length of residence in Canada could have a protective effect, which for others may have could have a increased risk for developing drinking and alcohol-related problems. So the question is, why is this happening? What are the reasons and what factors contribute to decrease in or decline in immigrant mental health? The evidence shows that the key factors which influence population health are income, social status, education, social and physical environment, employment, working condition, and other factors listed here. For example, what we do know is that in Canada, people who are low-income Canadians are more likely to die earlier and more likely to suffer a number of health problems than those on a higher income. Unemployed people also have a reduced life expectancy and suffer significantly from mental health problems than people who have jobs. Oops. Okay, so again, what evidence shows that risk factors for many common mental disorders are strongly associated with the social inequities. So the groups that experience more, they're more likely to experience social inequities are also at a higher risk of developing mental health problems. And similarly, the findings for the increased rate, the studies that found the increased rates of psychotic disorders also found that multiple socioeconomic factors influence people's mental health and increase their risk of developing those disorders. So determinants of mental health are general for immigrants are usually looked in terms of pre-migration, migration, and post-migration factors. So the reasons for migration, circumstances surrounding migration, and the reception in the host country are among the key factors that influence immigrant mental health and well-being. And they could be either risk and protective factors. Unfortunately, immigrants are more likely to be exposed to determinants of health that promote mental health problems. For example, a study found that recent immigrants are overrepresented among the hidden homeless population in Canada. A study conducted in Toronto found that 1 out of 3 homeless people in Toronto actually is immigrant. More graphs and charts. about income. Income is a key determinant of health and determines the degree of control that people have over their life. And again, new immigrants are one of the group that is more likely to experience persistent poverty in Canada. Income level of Canadians, comparing income level of recent immigrants, long-term immigrants, and the Canadian-born population, again, shows that recent immigrants who are working tend to earn less than other Canadians. Study found that underemployed immigrants, those who are overqualified, are more likely to report decline in their mental health than immigrants who are in jobs that suit their education or experience. At the same time, immigrants are also less likely to be employed than the Canadian-born counterpart. There is a study that looked into employment rates of immigrants aged 25 to 34 over the period from 1991 and 2010, and again, consistently found those lower rates. Discrimination. Evidence shows that experience of discrimination is a key determinant of mental health, and discrimination is more commonly experienced by racialized groups. Perceived discrimination influences mental health directly through increased psychological stress response, and also indirectly through limited access to resources and opportunities. Oh, okay. Barriers and facilitators of care. So again, sometimes the need for services is more relevant than simple rates of mental illness. And as I said, immigrants are more likely to be exposed to those factors that increase their risk of developing mental health problems, but they also face a number of barriers when accessing services. Language is, as we know, one of the key determinants of health unique to immigrants. And again, it is not something that is specific to new immigrants. We know that people who are not fluent in English less likely to use preventive services. Inability to speak English leads to increased hospitalization rates, longer length of hospitalizations, high emergency department use, reduced adherence to treatment, etc. But we also know that interpreters are mandated in the court system, but this is not the case in a healthcare system. So availability of professional trained interpreters, this is not something that is consistently available through healthcare system. People who, again, people who may be fluent in everyday language and able to communicate without problems in everyday situations would need interpreter in healthcare settings. Stress, mental health problems, decrease people's ability to communicate in a second language and properly describe their emotions and problems and their needs. Awareness of services. Many immigrants are not aware of services that are available for them. And if they are aware, if they are looking for services, they don't know how to navigate the system. Because of stigma attached to mental health problems, they are less likely to ask for help. Transportation cost, services that are available only during work hours, the location of services, and cost associated to certain medication is a significant barrier for people seeking help. Perceived discrimination, again, this doesn't mean that health service providers openly or directly or purposely discriminate against immigrants or refugees, but the ways that healthcare system works and the barriers that prevents people from receiving good quality care are perceived as a discrimination. Stigma attached to mental health problems exists in each and every society, in each and every cultural groups, but the level of stigma differs across cultural groups. So in some groups, mental illness affects not only person who suffers from mental illness, but the family as a whole. So seeking help is not always individual decision. Pathways to care. A number of factors influence people's pathways to care. For many immigrants and refugees, the first line of treatment are informal sources of support, local communities, family, friend, religious leaders, lay healers. After that, the second line of treatment would be family physicians, and after that will be mental health services. And again, services culturally relevant or culturally appropriate services are the expectation, than the norm, and the therapies that are developed for general population are rarely culturally adapted. So services are not always or often not perceived as relevant or useful to people from different cultural groups. And again, going back to countries of origin and a shift in immigration trend and who is coming to Canada. So the models of services that are developed are not necessarily relevant to all groups and useful. So what can we do? The Issues and Options paper that was published or developed for the Mental Health Commission of Canada outlines the key areas that need to be addressed in order to improve mental health of immigrants. Change focus towards prevention and promotion. That means development of policies that focus on decreasing the impact of social determinants of health and specific risk factors unique to immigrants and refugees. And in general, focus of services would need to change to embrace prevention and promotion. That includes strategies that target specific groups, for example, initiatives that focus on reducing stigma in certain groups. Improve data collection. We need more local data about the needs of different immigrant groups in different provinces and cities. Equity lens. Using equity lens when planning services and implementing. And one of the examples would be Health Equity Impact Assessment, which is a simple tool developed by the Ministry of Health, Ontario Ministry of Health. And the purpose of this tool is to help users to identify and address potential unintended impact of the policy, program, or initiative or service on marginalized populations. Better links between services and communities. This includes better links between settlement sector and the health sector, but also better links between health sector and the communities they serve. So understanding the views of the people they serve, and including immigrant communities and members, including consumer survivors and their families in the program planning and development. Development of more appropriate services, services that are culturally competent, services or therapies that are culturally adapted. One example would be just evidence shows that culturally adapted therapies are more effective than therapies developed for general population. So culturally adapted CBT is simply one example. Better training or cultural competence of service providers. This is something that is seen as a mandate, is something that should be a part of the regular training. Linguistic competence, provision of trained and professional interpreters. We should stop using family members and other service providers as interpreters. There is enough evidence that says that negatively affects the quality of care people receive. And the capacity building, as I said, in clinician skills. So what is happening? The Mental Health Commission of Canada Strategic Direction 4 focuses on decreasing disparities in risk factors and improving access to services for immigrants, refugees, ethnocultural, racialized groups, and Northerners. So building on this strategic priority, the Mental Health Commission of Canada has created a case for diversity, which is a project that is going to outline benefits of investing into culturally, linguistically, and safe services for immigrants and refugees and ethnocultural racialized groups. This project is underway. It includes comprehensive lit review. It includes consultations across Canada with a different level of stakeholders, government level, service providers level, and the community level, and includes some data analysis, includes a cost-benefit analysis. And the final report is going to be ready, I think, by sometimes in October. I'm not going to talk more about this project, but Bonita Varga, who is with Mental Health Commission of Canada, could provide more information about the project and consultations and other components of this project. And I think that's it. I'm just going to leave you with one resource, which is if you would like to learn more or find out more about mental health and determinants of mental health and treatment options for immigrants and refugees. This is a project that is funded by the Citizenship and Immigration Canada, and it's free for Ontario service providers, health and social service providers. I think that's it. Thank you.
So I was very interested in your talk, and one of your slides surprised me. That's the one that shows that the mental health, at least for the neuroses, actually deteriorates after immigrants arrive in Canada over a period of about 6 years or so. When I came over here, in fact, I think my level of euphoria increased when I arrived in Canada, so that surprised me. But I think if you were to analyze the figures according to whether those people succeeded in getting the appropriate job for their level of education, then I think the information will be far more useful, because you'll probably find that those who did not manage to find the right job and right recognition and so on, these are the ones that have gone into anxiety and depression, whereas the others did not. And I think your graph will go this way.
I agree with you. There is a study actually that looked into a self-reported mental health of immigrants based on their employment. And again, as I mentioned, I think that the study found that immigrants who are overqualified for the jobs that they have, meaning that they are underemployed, are more likely to report mental health problems and decline in their mental health than immigrants who have a jobs that that are based on their qualification and experience. And similarly, people who are unemployed are more likely to report poor mental health. Again, this is based on this is not my data. This is data based on the longitudinal survey of immigrants. You can have this data expert if data is correct or not. But again, you're right. We know that the reason why people report decline in their mental health is after this period of euphoria, or honeymoon period, what it's called, difficulties finding job, housing, income, social exclusion, and those factors affect people's mental health.
And do we have any resources to help that segment of the population?
Do we have access to appropriate jobs? And I think the whole day today was discussion was about how to improve access to proper jobs for immigrants and better integration. That's the key answer.
Ma question concerne les immigrants francophones d'Ottawa. So my question is about francophone immigrants in Ottawa. And the question is that given that there's a very large number of immigrants coming from Haiti and other francophone countries, the discrimination for immigrants is often, they're already were marginalized, coming into a francophone community that itself feels marginalized. I'm curious around is there any studies done on this group, whether in terms of data collection or mental health?
There are few studies, not that many published. There are few studies that have been published on mental health of francophone groups in Canada. And comparing Anglophone and Francophone. There are few studies that look into mental health of different ethnic groups and immigrants from different ethnic groups. But there are several studies that looked into impact of discrimination, in particular racial discrimination and mental health. And found definitely a direct association between, strong association, between perceived discrimination and poor mental health and mental health problems.
Alors pour les francophones, c'était une question très importante sur la situation des francophones, des immigrants francophones. Déjà, la communauté francophone doit composer avec une discrimination. Ça, c'est la population qui est déjà ici. Les immigrants francophones qui viennent et qui vivent la même discrimination, en plus des problèmes que vivent les nouveaux immigrants vis-à-vis de leurs attentes quand ils arrivent et de ce qui se passe après leur arrivée.
To what extent are you doing gender disaggregation of the data that you're examining and analyzing? I think that research so far has demonstrated that there are differences between the experiences of men and women, both in terms of the labor market and in terms of mental health. And I've been struck all day today, in fact, by the gender blindness of the discussions. Everything has been the immigrants as sort of a universal homogenous group, and I'm a bit concerned, and I'd especially like to address it in terms of your two presentations, since it's now that I'm asking the question.
I can talk about immigrant mental health. There is definitely gender difference. Again, I showed so many tables and graphs, and the tables were too small. You couldn't see the numbers, but one of them show gender gap. So in terms of mental health and self-reported mental health that declines over time, women are more likely to report poor mental health than immigrant men. And again, this is directly linked to socioeconomic factors and the strain that it's put on immigrant women in Canada.
My question is for the madam who talked about mental health. When you were giving your workshop, you said something about the family being affected if there is maybe one of the family member who has mental illness, and that can also help, affect the whole family. It's not just that individual. So my question is for the children, like children who come into the country, maybe at the age of 2, 3, 4, 5, and their parents or them are affected mentally. What are the like programs or activities or things that could actually help those children that are in school and they don't feel that they are being stigmatized? What are the things that those children, like activities those children that can help those children that have such mental illness?
So there are programs, there are good pockets. I would just, we looked into promising practices and services that focus on mental health of immigrants, refugees, and racialized groups across Canada. There are good examples of programs. There's good examples of programs that are available for children. They're more like health promotion and prevention children. Some of them attached to schools, some of them attached to community-based organizations. There is a program or organization in Toronto called Canadian Centre for Victims of Torture that provides services to immigrants, refugees, and victims of war and torture. And they have special programs for children, which are health promotion programs. So that would be the programs that would help children, again, talking about the children who experience problems or difficulties because of their parents' mental illness or because of their own
illness.
Because of their own. Again, there are programs that are developed specifically for children. Some of them are health promotion programs focusing on helping children overcome difficulties. Again, you know, there is a difference between mental health problems and illnesses. So not everybody needs psychiatric treatment. So there is a lot that we can do for immigrants, refugees, and children and adults, which is not necessarily psychiatric treatment or medication. So there are different programs, group and individual programs that can support their mental health, so health promotion programs. So again, Canadian Center for Victims of Torture, they have a health promotion for children, they have art therapy, you know, they have a drama, they have a different programs that...
Can you tell me the name again? You said...
Canadian Center for Victims of Torture, okay. CCVT.
Je sais qu'en matière de santé mentale au niveau des immigrés et des personnes réfugiées, il y a beaucoup plus, elles ont tendance à aller vers les organisations du secteur tertiaire plutôt que d'aller dans le mainstream hôpital ou dans les centres de santé. Alors je voudrais savoir, est-ce que vous pensiez qu'il peut y avoir un moyen d'intégrer ces organismes tertiaires, ces organisations au secteur plus formel, notamment le secteur primaire et le secteur secondaire? Est-ce que vous pensez qu'il y aurait un moyen plutôt un moyen de partenariat entre ces différentes formes d'organisation, de manière à bien pouvoir prendre en charge les personnes immigrées et réfugiées souffrant de problèmes mentaux? Et au cas où vous pensez que c'est correct, quelles sont justement les différentes perspectives qu'on pourrait avoir, qu'on pourrait mettre en place pour pouvoir travailler en tant que secteur tertiaire avec les organismes plus fonctionnels comme les hôpitaux et les centres de santé? Merci.
But like a question that was asked earlier about linking organizations, the tertiary organizations and institutions like hospitals and mainstream centers to help immigrants with mental health issues or illnesses. So she wants your ideas on that.
We are currently, as I said, looking into promising practices that exist across Canada. We have identified some good programs. Unfortunately, there are just pockets of good services. We are looking how they could be replicated in other settings. We need system approach, but there are some good examples, not only in Ontario and in Toronto. I think that there are some programs that are being developed in Ottawa. In Toronto, there is a model of services that is being developed that to respond appropriately for mental health of immigrants and refugees. That includes capacity building for all service providers, health equity training, clinical, culturally adapted CBT training, and different programs, and includes collaboration between hospital, settlement agency, and the community health center. Again, this is just one example. There are several examples in other cities. We will have, and again, Bonita can provide more information when this information will be available on Mental Health Commission of Canada website, but this is what we are looking about, promising practices and how they could be replicated in other
Ok, en fait, sa réponse, c'est qu'il y a déjà des endroits au Canada où il y a des pratiques exemplaires en la matière, et vous pouvez vous renseigner auprès de Bonita après, et elle va vous diriger vers les exemples, dont l'exemple à Toronto qu'elle vient de mentionner. Thank you very much, everybody, for all of your questions. And of course, the presenters are still here if you have other burning questions that you'd like them to address.